It is my pleasure to introduce Dr. Sarah Sitka, who hails from University of Washington, where she's an associate professor of urology. She did her training at Harvard and her residency at MGH, and then her urologic oncology fellowship at Mayo. And then after that, she was an attending at Cook County for a couple of years before moving over to UW. And if I went through, I can keep talking. Okay, if I went through all of the accolades, I'd take up this whole 45 minutes of her time. So I will keep it brief. But at Mayo is when she really developed her interest in sarcopenia and frailty. And you're going to see the evolution of that over the past 10 years, where she's really focused in improving surgical outcomes and has a Gemstar Award for her research that she'll be talking about today. And aside from that, she's a great auntie to my kids and has been a very dear friend for now almost 15 years.
Well, good morning, everyone. I am absolutely honored to be here today, and it's an honor to get to visit my kiddos from another city and also to visit you all. This is a department that I hold in the utmost esteem, and I think a lot of the work that I'm going to do here very much, I think, follows in the path and the trajectory of a lot of the thought leaders that are in this room. I'm hearing a bit of an echo. Yes, it is. Is that better? No? Okay. All right, well, hopefully that won't become a problem. So what I want to do today is tell you a bit of a story and really walk through kind of the evolution of sort of some of my thought processes over these last couple of years and talk a little bit about going from sort of problem to solution. These are my disclosures, none of which are particularly relevant for today. And so the brief here is to talk about how we develop a data-driven approach to characterizing patient risk. And I really want to think about how then once we understand risk, we can start to move the needle on risk. I also want to talk a little bit about how I have thought about developing this research program. Is that better? Oh, that's so much better. Okay, wonderful. So I want to talk a little bit about some lessons I've learned as I've kind of gone through these last now 10 to 15 years in training and really thinking about how to sort of develop the trajectory of a research program. So this is how I spend most of my days, which is very similar to how many of you spend most of your days. I'm a bladder, kidney, and testis surgeon. And by the virtue of the nature of the diseases that I take care of predominantly older patients who have a high burden of comorbidity, oftentimes live and thrive in very complex social situations. And because I work at UW, we are the primary referral center for the WWAMI region. That's 5 states that makes up over a quarter of the US landmass, but actually contains only about 3.4% of the patients of the country's population. But that means a lot of our patients are traveling pretty far to see us for very complex medical problems. And so we have to navigate thinking about how to optimize care in the context of a pretty challenging care delivery situation. So when I think about the windows of opportunity that we have to improve outcomes for patients, we have done so much work in our field over these past really 2 decades in terms of increasing adoption of minimally invasive surgical techniques and really growing our skill sets to do a better job of developing complex medical care to very complex malignancies and clinical scenarios. This can be extrapolated easily beyond oncology. We've certainly seen a rapid uptick in the adoption of enhanced recovery after surgery protocols, and I think that the survivorship science and the adoption of survivorship pathways is something that's really exploded and has had substantial implications for how we care for our patients and the outcomes that we've seen flourish. But I would argue that it all starts at the beginning. It starts when we meet patients for the first time, and where we can really improve outcomes is when we determine what options are best for our patients. And that comes down to how we risk stratify patients and how we choose the right treatment, for the patient. And then beyond that, once we've figured out what a patient's risk profile looks like, how do we optimize them in preparation for the treatment that we're going to ask them to go through? So one of the things at UW we ask all of our fellows to do when they start is to write down their research mission. I'm the associate program director for our fellowship, and I was like, well, if I'm asking everybody else to do it, I need to do it for myself. So this is my mission. My mission is to improve clinical and oncologic outcomes and health-related quality of life for patients with GE malignancies by developing and validating objective and reproducible personalized risk stratification procedures, and then figuring out how to develop targeted interventions to reduce treatment risk, treatment toxicity, and treatment burden. And I think that, frankly, I can talk for the next hour, but it really comes across, I think, a lot more strongly when we hear a patient talking about what this problem is all about. So this is a patient who gave us a bit of an insight into what many people in his situation are thinking, feeling when they come to see us for the first time. And I think this sets the stage for what we're going to talk about. Oh, okay, hold on one second. So now we're going to just... Okay.
Well, cancer, just say you got cancer, sure as hell, I thought I was. And so, the fact that, no matter what, when I came in to see him, he said he didn't know if I was able to do the surgery. And that, we would look at that, well, I didn't want the surgery because I didn't want to downsay, you know what I mean? I want to live as long as I can.
So, I mean, who says it better than that, right? There's all the complexity in one. Can I get through the surgery? Should I even have the surgery? I don't want to die of cancer. I don't want to die from the surgery. What do I do? So this is something that confronts all of us, right? And this is the problem that when I was first kind of getting into this field, this is the thing that would really stick with me and kind of keep me up at night when I was actually making my indications. And the question is, how can we define surgical candidacy? And furthermore, how can we access it? So it's really easy if you see someone who's kind of routine come in. 55-year-old male, otherwise healthy, little kidney cancer. Okay, I know what I can offer that patient. The guidelines are pretty clear, but how often do you actually see that? More often, this is what we see, right? It's somebody who's a little bit older, who has a substantial burden of comorbidities, and because of that, the decision-making becomes incredibly complex. And so we're really good in 2024 at talking about cancers. We can characterize them with respect to stage, grade, histology, clinical characteristics. We can get into all of the multi-omics and start to really do a very detailed characterization of risk. We can start to think about personalized medicine. But I would argue that what we really need to start thinking about is how we characterize the patient within whom that cancer resides and start applying the same degree of rigor with respect to how we characterize patients. And so that's what I've been kind of working on. Conventionally, we utilize things like age, comorbidity burden, nutritional surrogates, and performance status to try to characterize risk. But I would argue that a lot of these risk stratification tools ultimately fall flat in discriminating between patients who have either very little surgical risk or a substantial burden of clinical risk. And that's because none of these tools were validated or developed to tell us about the risks that we as surgeons care most about. This is a study I did a long time ago now where we just looked at all of the different papers that were out at the time that were looking at outcomes after bladder cancer surgery. And for every paper where ASA or Charlson Comorbidity Index was statistically significantly associated with one of the outcomes that we care about, like major complications at 30 days or death from surgery or cancer-specific mortality, I could find multiple other papers in which the multivariable models, those characteristics fell out. And again, it's because those characteristics were not validated for the outcomes that we were looking at. Furthermore, we think as surgeons we're actually pretty good at assessing risk, but the truth of the matter is if you look at how we assess for performance status, not only is it very different from how patients assess performance status, because patients are taking into account their social and emotional well-being as well. We also tend to overestimate how long our patients will live, and maybe that's the optimist in all of us, but that's actually really important when it comes down to helping patients understand what is the right treatment for them and giving them accurate estimates of what life is going to look like after surgery. And the truth of the matter is, when you sit with a patient in clinic, the calculus that your brain is doing is incredibly complex. You're not only weighing the tumor characteristics, the technical considerations, your team, and all the resources that you have at your disposal. I'll tell you, the calculus was very different when I was at Cook County than it is now for me at the University of Washington because of the resources and the team that I had available to me. But you're also trying to put together this understanding of the patient factors that actually, again, that's what we're really getting at, is how do we measure those? So you're measuring reserve versus risk. And when you try to do that pretty quickly, it's a pretty nebulous calculation. And importantly, it's really hard to do well because the tools we have at our disposal don't tend to perform to sort of the degree that we wish they would. They're not terribly specific. They're very, very non-granular, and it's really hard to reproduce. So we fall back on this eyeball test, this gestalt impression of fitness or candidacy for therapy. But again, it's really hard to teach. It's really hard to reproduce. It's hard to study, and we may not be as good at it as we think. And there's major consequences to us not doing well in this regard. We risk both undertreating patients and not allowing patients access to therapies that would benefit them potentially in terms of neoadjuvant chemotherapy, adjuvant immunotherapy, or major surgical interventions that might ultimately save their lives. We also risk overtreating patients and exposing them to excess morbidity and risk of mortality. So we need more data. And this brings me back to a commencement speech that I heard when I was in medical school. So I'm sure everyone in this room knows who Atul Gawande is, and he's one of my sort of favorite people to read. But when he was giving his commencement speech in 2005, he said, no matter what you ultimately do in medicine, a doctor should be a scientist in his or her world. In the simplest terms, this means we should count something. If you count something interesting to you, I tell you, you'll find something interesting. And so ultimately, here's our knowledge gap. We need to understand how to characterize risk and candidacy for therapy in a data-driven fashion so that this can drive not only further testing, but optimal treatment solutions and potentially also those interventions that optimize candidacy for therapy with the goal of getting patients through their therapy and into survivorship to the best that we can. So in 2013, I was finishing residency and I was moving to fellowship. And this was, I would say, the pinnacle of the BMI research sort of fascination. Everyone was doing BMI research. We were all trying to figure out, in the setting of this explosion of obesity, how does that impact outcomes? So I started studying it too. And interestingly, what you find is that no matter what paper you read, BMI has different associations. This was a paper that one of my mentees wrote using the NSQIP database, which showed that paradoxically, complications after radical cystectomy were the highest in those patients with the lowest BMI. And if we look at the survival data, there were multiple papers that showed either that BMI was not even close to being associated with survival after cystectomy. BMI was associated with, the highest BMIs were associated with the worst outcomes in terms of mortality. And then there were other papers that showed that actually obesity is protective. And across cancers, we see multiple papers that are showing this paradoxical finding that the patients with the highest BMIs have the longest survivals. And so this has been termed the obesity paradox. My first foray into research actually was when I was in medical school, was working in Dr. Judah Folkman's lab. Now, he's probably also somebody who doesn't need much of an introduction in this room as the father of angiogenesis and the person who won the Nobel Prize for discovering that. And I was pretty lucky that he took me under his wing. And if you read the book, the biography written about his life, you realize that angiogenesis was discovered because of an experiment that went horribly, horribly wrong. But instead of throwing it out, he did another experiment to figure out why it went wrong. And that's how he figured out how cancers recruit blood cells towards them. And so he always used to say, you've got to pay attention to the things that don't make sense. So I started thinking about this obesity paradox question. And there's been a lot of sort of theories that have been put forth to try to explain it in terms of other factors and confounders. And I think that reverse causation and unmeasured confounders have sort of been sort of arisen to the top as the chief hypotheses that explain this obesity paradox. But one other question I had was, well, what if we're not talking about what we think we're talking about? And when you think about obesity, well, obesity defined by BMI is simply weight stratified by height. Right? But what is weight? Well, weight is everything that we're made of. And of course, we all know that patients who are fairly heavily muscled are going to weigh as much in the same sort of taking up the same amount of volume as someone who maybe is a little bit less fit and carries a lot of adipose tissue. Dr. Vicky Barakos is an oncologist in Calgary, in Alberta, who was really leading the charge in the sort of early 2000s at talking a little bit more precisely about body composition. And when I was a fellow, I started reading her work, and she had figured out a way to leverage opportunistically the CT scans that we all obtain in clinical practice to stage cancers and surveil cancers and measure muscle mass and fat mass. And she was able to validate the fact that from the cross-sectional measurements of areas, we can actually calculate total body compositions, fat-free and fat mass, without DEXA scans and exposing patients to unnecessary radiation. She very kindly shared her methodology with me, and I was able to learn from that. So we started deep diving this in our cancer population, and we looked at how well does BMI describe body composition. Well, the fact of the matter is it doesn't do a very good job of it. You can have normal fat mass and normal skeletal muscle mass, and your BMI can range from underweight, less than 18.5, all the way up to class 3 obesity by the WHO classification criteria. Similarly, if you look at patients with bladder cancer who have completely normal BMIs, they walk into your office and they don't raise any red flags whatsoever. And actually only 12% of them have a normal body composition, and 83% have a severe paucity of muscle mass. We started getting into this and trying to understand, well, what does it mean? And we found pretty quickly that low muscle mass is independently associated with really inferior survival outcomes, a twofold increase in death from both cancer and any cause. And this was something that we found in bladder cancer. It's something that's been then demonstrated in multiple other series, and Christina Billibor led this nice systematic review showing a fairly similar 1.5 increased fold risk of mortality. And it's also associated with complications. And we've been able to demonstrate this now across multiple other malignancies. And this is something that I think at this point, the associations between muscle mass and outcomes in cancer are really well understood. And it's something that the oncology world has started to pay a lot of attention to. But I'm a big proponent of going at things as a team. And so one of some things that some of you may know about me is that I was a rower in a former life. And we had when I was in college on our locker room wall, this quote by Rudyard Kipling: "For the strength of the wolf is the pack, and the strength of the pack is the wolf." And the truth of the matter is we go a lot faster when we go together. And so this is something that I was starting to get really interested in, but I realized I couldn't do it alone. And truthfully, when you go fast, sometimes you do great things. And our team did win the NCAAs my senior year. But team science is really where it's at these days. And so I've been very fortunate because I have a number of incredible collaborators, and I want to highlight a lot of the work that we've done together. So Viraj Master at Emory and I have been deep diving the interactions between muscle mass and inflammation, and how that additive insult really does influence outcomes in patients with cancers. And this is something that we recently put together in a review article, trying to share, to try to actually understand even more the interaction between inflammation and muscle mass loss, and sort of try to unpack the temporal nature of what is likely a fairly circular process. Cancer causes increased catabolism. Catabolism causes muscle mass loss. Muscle mass decreases reserves. And all of a sudden we get into this vicious cycle. And that's something that we're trying to get to. But the other part of all of this is that it's not just the person, it's what we're doing to them. And a lot of times, some of the treatments that we offer patients actually put patients at risk for really inferior outcomes. One of the things you see oftentimes in patients who start chemotherapy is that their muscle sort of ostensibly wastes away or melts before your eyes. But nobody had ever sort of documented this before. So when I was in Chicago, In a small series of patients, we identified the fact that within a median of 110 days, patients on neoadjuvant chemotherapy before radical cystectomy lost 6% of their muscle mass. Now, that's really important if you're thinking about a patient population that is already sarcopenic, has a prevalence of sarcopenia of 70%. So I went from Cook County, traveled across the country, was lucky enough to get an opportunity to work at UW, and we've been able to validate this in a much larger series, and the signal is the same. So we're talking, again, about a 6 to up to 9% in some series muscle mass loss while patients are receiving neoadjuvant chemotherapy. And this signal is actually replicated across disease processes and systemic therapies, regardless of mechanism. So here you're looking at targeted agents in metastatic kidney cancer and in younger patients, patients with testicular cancer undergoing multi-agent cisplatin-based chemotherapy. We see not only a substantial loss in muscle mass, even in patients who are starting with a normal muscle attributes, but importantly, that muscle mass loss, the patients who lose the most muscle, are also those who are at the highest risk for adverse events related to the chemotherapy or during chemotherapy. One of the biggest, I would say, bottlenecks in this research, and the thing that is limiting its extrapolation, utilization more widely in our field, this is actually really hard to do this work because it requires basically coloring in by numbers, trying to measure and assess the cross-sectional area of muscle and fat on CT scans. It's really too complicated for us all to do in clinic. So it's not something that is, I would say at this point, ready for prime time. But one of the things that my team and I have been working on is actually harnessing AI to try to scale up the opportunity to use these tools and implement them in clinical practice so we can actually start to really get at risk stratification in a timely fashion, something we can do in clinic. But all I've been talking about so far are these radiomic biomarkers, and they seem to associate with outcomes. But the truth of the matter is they are at most just a snapshot in time of what somebody looks like on the inside, and they may not translate into function. And so while I was studying muscle, I got really interested in trying to understand, well, can we do better? And so this concept of frailty has emerged as a really important concept for us as surgeons to be aware of. So frailty is this global, multidimensional measure of vulnerability to stressors. And I'm going to show you how independently it predicts adverse outcomes, the outcomes that we all care very much about. It takes into account not only the disease process, but the patient's own individual sort of domains of vulnerability. And it's an incredibly powerful risk stratification tool. The problem is it's also a little bit tricky to measure. There's been over 70 different ways described to measure frailty, ranging from very, very simple pictorial descriptions to very, very complex hour-long assessments. Importantly also, frailty is dynamic and it changes throughout episodes of care. Patients can go from robust to frail and then back again as they go through therapy. And frailty is not just disability and it's not just comorbidity. It characterizes something else. So this is something we've been really trying to understand. Importantly, when patients have different burdens of frailty, they respond to stressors differently. And we kind of talk about this as the factor that determines how patients are going to bounce back. And importantly, it's very much associated with the outcomes that not only we as surgeons, but most importantly, our patients really care about. Frailty is associated with ability to tolerate the therapies we're asking patients to go through, as well as life expectancy. But it's also associated strongly with symptom burden, quality of life, loss of independence, and a patient's sense of dignity, which when you're talking to somebody, I think is incredibly crucial. In terms of how do we measure this in real life, well, like I said, there's a lot of different ways to do it. I think that the geriatric screening tools, we can borrow from the field of geriatrics and learn a lot because the geriatricians really have sort of obviously written the book on how to measure frailty, but they've created also a number of very easy to use screening tools that can be easily integrated into our clinical practice and identify those patients who are vulnerable who might benefit from a referral to our partners in geriatrics who can help us better understand our patients' risk. I use functional assessments, like a 30-second chair stand or a 5-time sit to stand. This only takes about 5 seconds in practice, and it tells you a tremendous amount about a patient's fall risk and their potential need for example, PT and OT after therapy, after surgery, so that you're optimizing the likelihood that that patient's going to be able to get out of bed, get back on their feet, and get back to their home living situation. Physical activity as a vital sign is another great way to really understand, in just 2 questions, how much work your patient is actually able to do, so that you can understand what kind of activity prescriptions you can start to think about advising them on. And then cognitive frailty is something that I've recently become really interested in, and I think it's a field that, as surgeons, we need to be incredibly aware of how our patients' ability to process the information around them impacts their outcomes after surgery. This is a really bright, smart paper that was written and led by Viraj Master and some of his colleagues at Emory, looking at a surgical oncology population, basically demonstrating that patients who had physical frailty were at a 2-fold increased risk for mortality after surgery. But if a patient screened positive for cognitive frailty in addition to physical frailty, that increased risk was actually 4-fold, and that's substantial. But the question is, how can we do this even better? And ultimately, I think one of the tools that actually really starting to try to listen and learn from my partners who are geriatricians that I've become aware of are these comprehensive geriatric assessments. And I'm going to tell you a little bit more about my GEMSTAR. But this has been a tool that I've been trying to figure out, how can we integrate these tools into our oncology practice. So a CGA is a multidimensional evaluation of a patient's health. They can identify potentially modifiable or subtle risk factors to improve outcomes. And really importantly, a CGA gets at that concept of physiologic age instead of chronologic age. And it identifies vulnerabilities that we may not pick up just by asking a patient kind of how they're feeling and what their comorbidity burden is. I like this statistic. 50% of older patients with cancer who have a completely normal ECOG performance status, so can get onto all the clinical trials, actually need assistance with their activities of daily living if you ask them about it. Their ability to toilet, to bathe, to make food, to dress. As a surgeon, don't you want to know those things? So, and what do the guidelines say? Well, the guidelines say we should actually be doing this in our patients, but it's actually challenging to do in clinical practice, despite the fact that there's pretty wide acknowledgement of the value of the data that we get from this. In patients with cancer who are undergoing surgery, CGAs predict those outcomes we care about. They can predict ICU admissions, early mortality after surgery, discharge to places other than home, which patients want to know about. And if you do a CGA in the hospital and identify vulnerabilities that then you can then act on, you can reduce the risk of things like complications and postoperative deliriums. This is another one of my favorite statistics. An older patient who undergoes a CGA in the hospital is much more likely to get home after surgery and a year later still be living independently in their home. That's an outcome our patients want to know about. But again, CGAs, if they're done properly, can take up to 2 hours, require a board-trained geriatrician. And as surgeons, it's not something that's a part of our education. I certainly had never even learned about this until I was years into trying to study frailty. And so I think it's something that we need to think about, how do we integrate? And there are a couple people who are doing it really well. So the Memorial Sloan Kettering program has developed this electronic rapid fitness assessment. It's something that their patients fill out before they even come to clinic. And Bernie Bachner and his group and Alvin Go have recently published on the fact that their ERA or their ERFA has basically been very statistically significantly associated with those outcomes that, again, after radical cystectomy, we worry about: patients winding up in the ICU, having an early death, being discharged to a rehab facility. And Angie Smith and her group also showed that if you do this, you can start to really get into the concept of functional decline and functional trajectories. CGAs also capture that the temporal changes in frailty that happen over time with our episodes of care. So we got into this. I was lucky enough when I was a couple years ago when I first got to Washington to have a Young Investigator Award from the Bladder Cancer Advocacy Network. And they sponsored us, basically trying to figure out how to integrate this into our clinical practice. And in 1 year, we enrolled about 94 patients onto a study where we did CGAs in our multidisciplinary bladder cancer clinic. I'll clarify that this was in the heart of COVID, so we had to be pretty nimble. We had to deviate from our protocol and figure out how to do this by telehealth in the middle of the pandemic. What we found is that one, it was doable. Two, it only added about 18 minutes to a clinic visit, so the patients would do it while they were waiting for their physicians to come see them. And we asked patients, does this increase your burden? You're in this busy clinic, you're dealing with this new diagnosis. Most patients said it was really not associated with substantial burden at all, and they were happy to go through it. And we found pieces of information that we never would have found otherwise. We identified, for example, substantial nutritional risk in up to a third of patients and malnutrition in 6%. We identified mild to moderate dementia in 3% of our patients that had never been characterized before, and also identified substantial mental health risk factors that allowed us to get patients to our cancer centers' psychiatric resources, which I think is an important, has been demonstrated in the literature to be an important prehabilitation point. But one of the things that I started thinking about was, okay, well, we're finding frailty, right? Like all of these risk factors collapse down to frail, yes, no, a dichotomized variable. But you're also getting all of this incredible data. And actually, one of the biggest issues I've had with this is I have so many data points, it's really hard to put it all together in a manuscript. And we're struggling with that. So one of my amazing mentees from last summer I asked her, we started looking at the correlations. We're like, all of these different domains, do they actually give us just the same information? Could we just ask one question and save these patients that 18 minutes? And the truth of the matter is, all of the different domains, there's actually very little correlation. And patients who have quote unquote vulnerability or frailty in one domain may not in another. So if we just say they're frail, well, we're actually losing all of that data that we just collected. So we're trying to work on this concept now of kind of deep phenotyping frailty and getting into what I'm calling vulnerability phenotypes. And we're working, this paper is under review right now, where we're thinking about how to create a visual depiction that helps delineate and differentiate patients based on the areas, the domains of vulnerability, where they have these problems, and so that we can really target those as actionable vulnerabilities that we can try to mitigate. And then this is the lessons learned. My first attempt at doing CGAs in practice, well, I learned that I was making it a lot more complicated than it needed to be. And so, but one of the wonderful opportunities of working within the Gemstart community is I've been able to learn from a lot of geriatricians. And Grant Williams is a real thought leader in this field, and he and others have validated this very rapid self-reported CGA tool. It takes about 10 minutes, and older patients can do it pretty easily. It gives you all of the information. And so I just have patients fill this out as part of their pre-clinic paperwork at this point. And we've been able to start to really capture this data very efficiently, and then start to understand quickly when you see a patient. You don't actually have to ask them all of those different questions or put them through a battery of tests. You can quickly review the paper before you go in, and you know that this is a patient who you've got to be worried about their mental health. This is a patient who you've got to worry about the fact that they lack social support at home. And so maybe you need to get social work engaged a little bit sooner. So as we're studying frailty, a concept that has really bubbled to the top of sort of social discourse is this whole concept of resilience. And that's something that, as we're talking about vulnerabilities, I've started to think a lot about. Because I think you probably all know this. When a patient comes in and you give them a new diagnosis of cancer or another illness, the way in which that data is received tells you quite a lot about the patients, but sometimes it's pretty hard to put your finger on how they receive that information, like how do you characterize that? So resilience is this concept that's really, I think, important. It describes an individual's ability to maintain psychological and physical functioning in the face of stressors. And so one thing I've been thinking about is, well, is resilience really an effect modifier for frailty? So with normal healthy aging, unfortunately, and this is as someone who's entering her 40s, I'm thinking about this a lot, like you start to see some declines, right? But then when you have a diagnosis of cancer or a major other illness, that decline slope is accelerated. And then we treat them. And then it declines further. And some patients will recover on one slope. But my question to you is whether or not resilience can actually start to change that slope. And so there's pretty good evidence that is emerging in the surgical literature that resilience, when you measure it, is actually associated with how patients recover from surgery. It's associated with pain medication utilization and pain reporting. It's associated with patient-reported quality of life and anxiety. So we kind of thought, well, if we're doing these CGAs, well, what if we actually started to measure resilience too? And this was we have a resilience lab at the University of Washington that's actually a lab within the undergrad campus that's associated with the Foster School of Business. So soon after I got there, I met with them and I said, hey, have you ever thought about measuring this in patients? And so we took a number of the validated tools that they were utilizing that measured things like psychometric capital, resilience, efficacy, thriving, and self-compassion. And we modified them to make them relevant and salient for an oncology patient population. And when we did our CGAs with the Beacon Project, we started measuring resilience too. And what we found was, one, these variables are all internally consistent, and you start to get a very clear understanding of certain variables, such as resilience and thriving. But they don't track necessarily with a lot of the other domains of the frailty assessment, although I just told you that most of those domains don't actually track with each other. So again, we're getting new data from these resilience assessments. There is a modest negative correlation with physical function, which I think is interesting. It's something that we need to look at in a much larger sample size. And also, not surprisingly, there's a negative correlation with mental health. So I think that this is something that, a work in progress in my lab is trying to figure out whether and to the degree to which resilience is a modifiable resource and how that interacts with this whole frailty concept. And maybe we can, ultimately figure out a way to turn the whole frailty paradigm on its head. But I want to pause for a second, because we've been trying to figure out if a patient is a candidate for treatment. We've been talking about risk. But how do we actually help that patient determine if the treatment that we're offering them is right for them? So traditionally, I've been telling you, we want to predict these outcomes that we all care about: complications, length of stay, survival. But I think that there's an increasing understanding of the fact that when you start to ask patients what they care most about, it varies between people. It's actually pretty hard to measure. It usually requires assessments of things like quality of life and patient perception and experience. So this requires a whole different degree of data collection. And this is a seminal paper from Terry Fried that looked at older patients with cancer and asked them how they prioritize outcomes. And one of the survey responses was 74% of patients said they'd rather die than undergo a treatment that would functionally impair them. And almost 90% said they'd rather die than undergo a therapy that would impair their cognition. And this is really important, because if we don't ask patients, what does a successful outcome look like to you, then we can't offer a patient the right therapy for them. And this goal elicitation is actually a cornerstone of guideline concordant care. But again, it's something that we have to be very thoughtful in how we ask patients about. And I don't know, does anybody know who Henry Marsh is? So Henry Marsh is a British neurosurgeon who's written a lot of really interesting books talking about complications in surgery and sort of how that weighs on surgeons. But he wrote a recent book, a recent biography, this is his third, that was actually about his journey with a prostate cancer diagnosis. And in the book he writes, the problem is, of course, that the patient wants to know what's going to happen to him or her as a specific individual. And all we can do is talk about what's going to happen to 100 patients with the same diagnosis. So anybody know who Emma McElroy is? So she is the leader of an inclusive clothing company. Her name, it's called Wildfang. But I'm bringing this up here because she gave this great TED Talk that I think is really, helpful in thinking about sort of the next steps in this work. She told this story. She was a kid on the beach in Ireland. She found a rock. She went up to her mom. She said, "Mom, I found the toenail of a great woolly mammoth." And her mom, instead of saying, "Emma, you're nuts," said, "Well, yeah, maybe." And the next day they actually took it to the local museum. Turned out she'd found the best preserved baby ichthyosaurus skull that had ever been found. She used this example to describe this concept of functional fixedness, which is this whole idea that we kind of know what we're looking at. We know what we're talking about, and we can't get any better at it. And she said that the two words that stand between you and your next big idea are those two, that, yeah, maybe we can figure this out, and talks about the power of an open mind. So I was finishing up residency, and I was about to head to Mayo for fellowship, and I called up my new fellowship director and I said, "Hey, I have this idea. What if we could figure out how to tell patients with small renal masses, what if we could tell them across the treatment options, what were the likely sort of outcomes that they would experience within each treatment?" Because all that was out there right now was personalizing risks for each specific treatment, but there was no way to put it all together for a patient. And he said to me, "Well, yeah, maybe we could do that. So we got to work and started to collect all the data and quickly realized that you need a lot more data than you could get from one institution. So he connected me with the folks at Toronto. He connected me with the folks at Hopkins in Michigan. And eventually we brought a whole lot of other very high-powered statisticians on our team. And it took about 10 years. But we amassed a patient population of over 5,000 patients, and we're ultimately able to map out treatment-specific competing risks to generate a calculator that we're working on validating right now that actually can be used in a clinic visit to not only tell patients what's the likelihood of cancer death if you have a partial or radical go on surveillance or ablate, but what's the likelihood that you are going to be alive in 5 years or 10 years, which helps patients to sort of start to weigh trade-offs. And then this got me thinking, though, because you probably are also aware of this amazing book by Atul Gawande, going back to him. In Being Mortal, he writes, "We've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it's larger than that. It's to enable well-being. And well-being is about the reasons one wishes to be alive. Those reasons matter not just at the end of life or when debility comes along, but along the way." So really echoing the work of Freed. And this gets to this whole concept of patient-specific outcomes and the need that we have in our field to actually characterize them. And these are outcomes that are actually really hard to characterize with standard metrics. So things like functional recovery, getting back to independence, cognitive trajectories after general anesthesia, maintaining independence. And so we have this need to really understand personalized treatment-specific estimates, not only of being alive because of cancer, being alive from cancer or being alive from something else, but how are patients living their lives during that time? So this is actually, this is the heart of my GEMSTAR. And within a bladder cancer patient population, we're prospectively enrolling patients and really trying to capture functional recovery trajectories. And then we're incorporating a lot of the work that we've done on muscle mass and frailty measures with the goal of being able to not only understand how people recover after chemo and radical cystectomy, but then trying to figure out if we can actually start to predict those patients who are likely to have a more challenging recovery trajectory so that perhaps we can intervene. So we got 44 patients enrolled after a couple of months. We're working hard. We're going to do it. This work takes time, but it is something that I'm really excited about because this is the kind of data, when a patient asks me, well, doc, when can I go visit my kids in Florida again? Right now, the best I can say is maybe 6 months, maybe 3 months, I can hand wave, but I don't have data to put behind that. So that's what we're working on. So now, we can generate comprehensive risk and resilience characteristics and profiles. We can maybe start to think about how we can estimate personalized outcomes that matter to patients. But as Chris Wood will say, well, what are you going to do about it? Time to put your money where your mouth is. So this is where we get into this concept of pre-ab. And so prehabilitation is the process of improving functional capacity before really any medical intervention to help patients withstand the stress of that intervention. There are 3 core domains: the physical, the nutritional, and the mental. And the whole idea is that with these multimodal programs, we can make people better candidates for therapy, and we can help them get through therapy better. And this really follows in the tradition of enhanced recovery after surgery protocols. The hype is if we do this, if we get people strong for surgery, we're going to reduce complications, we're going to shorten their length of stay, we're going to improve their body composition parameters, they're all going to be jacked when they come in. We're going to decrease cost and improve their quality of life. But the truth of the matter is the data that's out there doesn't necessarily support this. And a lot of the prehab programs that have been started have been less successful than we would have hoped. This was a summary that we wrote of a lot of the prehab programs that had been studied in 2022 that basically showed that although the programs were designed with the best intentions, they weren't hitting the mark on changing those outcomes that we really care about, with the exception of a couple that sort of were moving the mark a little bit, but not to the degree that we had hoped. And it comes down to a couple of key characteristics in terms of how these programs are defined. So one, I think, is actually thinking, we're going to get into this a little bit, but thinking about equity and how we provide care. A lot of these programs are very expensive. They require patients to travel far, come to a gym, do a 90-minute exercise intervention. I would like to do a 90-minute exercise intervention. So we need to be thinking, can we do this at home? The other thing is, are we moving the mark on the outcomes we care about? Does my 86-year-old who's in the hospital after a cystectomy, did he need to do high-intensity interval training and flip tires? Or did he need to practice his squats so he can get out of bed? We need to understand our target patient population and not ask people to do things that are not safe for them. And then we need to think about the financial toxicity implications of all of this. So at the Bladder Cancer Advocacy Network think tank, one of my partners, Hannah Hunter, who's a PM&R doc, and I have been leading this prehab outbreak session for the last couple of years. And in 2022, we presented this idea to everybody. And the patients were like, why did nobody ever tell me about prehab? Well, the truth of the matter is what had been tested at that time was kind of like the Lamborghini of prehab. And we probably need something a little closer to what I drive. And so, because the goal is not with prehab to turn patients into bodybuilders or have them running marathons. We're really thinking about how do we optimize functional recovery, be able to get patients safely in and out of bed, and again, get them home, get them back to their families. So I take you back to this, yeah, maybe comment. And if you're interested, we just actually published a whole edition in EU Focus where we got into the whole idea of how we can operationalize prehab and really bring it into contemporary practice and think about developing pragmatic solutions for prehab. And importantly, I think you'll start to see how it's something that we really do need to personalize. We can't just say, Mr. Smith, who's 64, and Ms. Black, who's 84, both of you are not doing the same exercise program. That's just not going to happen. So we need to think about personalized interventions. We also need to think about transitioning that to home to make it easier for people to do. We can leverage the wearables that we all are so obsessed with, and also think about how to incorporate artificial intelligence into operationalizing and increasing adoption of these protocols. And I think the other thing is it can't be just one intervention. ERAS protocols work because they work across so many different domains, and there's this 22 to 27 point checklist that improves outcomes. Well, prehab probably needs to follow that model too. And so this is one of the new trials, for example, that I think has a lot of promise that's being done in Belgium right now that's looking at not only at training and physical activity, but specific nutritional support, psychological counseling, and then also kicking bad habits like smoking. And we're starting to see shifts in those outcomes that we care about. We're actually starting to see the needle moved on length of stay in addition to ERAS protocols. So it's moving the needle further. So I'm just going to take a few more minutes. I know we're getting short on time, but I want to show you what we're doing right now. So in the setting of that, yeah, maybe. When Hannah and I were asked by patients, well, why can't we do this at home? We went back to UW and we started to talk and we were like, can we figure out how to make this work for all of us? And so we wrote this trial called the Get Moving trial, which takes exercise prescriptions and makes them home-based. They're 20 to 30 minutes. They're based on a patient's physical ability at the get-go, and they're delivered through an app that has been integrated with our Epic electronic healthcare system that was developed by our sports med team by Dr. Cindy Lin and her collaborators. Not only that, but one of the big issues with home-based exercise training is you can't necessarily check if a patient's doing it. Well, now we can, because your cell phones all have sonar in them, and sonar allows you to track activity. That's how, in addition to the sort of the accelerometers that track your step counts with your cell phones, there's also a way to actually measure movement. So we're actually leveraging that as well as some video-based feedback to assess participation in the program at home. And this is our trial schematic. It's for patients with bladder cancer who are going to go chemotherapy and then radical cystectomy. And we basically are randomizing patients to a prehab arm that's a personalized home-based prehab arm versus standard of care, and then tracking their outcomes, specifically looking at physical outcomes, as well as things like quality of life and functional dependence. And so as we kind of wrap up, I think we'd talk about prehab and say, yes, we definitely know at this point, if you're going to do it, you need to understand the person that you're prescribing the prehab to well, because it has to be an individualized prescription. There is no one-size-fits-all prehab that's going to work for every patient, but it does potentially offer substantial benefits for patients. It also is the question, too, when a patient asks you, well, doc, what can I do? This is something really positive that they can engage in. It's definitely ready for prime time. I think it has to be multimodal. And in terms of its ability to become accessible, scalable, and pragmatic, well, we're all working on that. And then the final thoughts, I told you we're going to talk a little bit about sort of developing a research career, and I think I've given you a couple of sort of the anecdotes that I think about. I think just to kind of sum things up, I would say, you know, one thing that has been critical for me has been the number of amazing mentors that I have had, and I also spent a lot of time thinking about how to mentor, because you learn as much from your mentees as you do from your mentors sometimes. I think you need to figure out what matters to you and then start counting it. and put some data behind it. I think it makes sense. I think when you see something that doesn't make sense, it's really important not to throw that in the bin. It's really important to ask why, because sometimes that will lead you down a whole track. I don't think if I had ever sort of started studying obesity and gotten kind of thrown off by this obesity paradox and just written a bunch of papers about the fact that this is the way it is, I don't know that I'd be studying now what I am studying now. And I'm really glad that I had a couple of people who sort of pushed me to ask why. And then I would say it's really important to write. I wrote this review article called Staging the Host back in 2018, and it really became kind of a launch pad for this whole sort of direction and research. And sort of it was a bit of a, for me, it was a moment in time when I was working at an institution. I didn't have a lot of resources. I couldn't do a lot of work. But I was thinking about, okay, how can we solve this problem of risk stratification, and how can we determine candidacy? And I found a bunch of people who worked with me, and we put our thoughts down and started to sort of lay out a charge for ourselves to put some data behind it all. And I would say that complex problems definitely require complex solutions. And it starts by actually defining the problem, and the problems come from the patients. The patients will tell you what they need if you listen. Then we have to realize that we can't do this alone. All of the things that we've talked about are leveraging the expertise from people from other fields where they are the true experts. And I think I've been lucky that a lot of them have been willing to teach me how to start to implement some of the lessons they've learned within GU oncology. It's all about building connections and then building these diverse teams and then innovating, iterating, and then doing it all again. And I probably don't need to talk to people in this room about DEI initiatives and how helpful they can be when you're building a research program. But capitalizing and facilitating and really making sure that you're thinking about creating diverse teams that are equitable and inclusive is really important when you're building your research team. And when you have equity and everyone has space and time to talk, all of a sudden you get innovation very much more rapidly than you would otherwise. Making sure that the microphone gets passed around and everyone can share their ideas promotes organizational success well, and not inequity, and not listening to people who have some really bright ideas sometimes loses opportunities, I would say, more often than not. And so one of the things I've really focused on is creating a culture within my lab and within the team that I work with of collaboration and sharing. And it's been working with the PM&R docs and the sports med team and the engineers and the geriatricians. They're the people who I've learned the most from. And I think that it's by working all together we've been able to create, I think, some interesting ideas that now we're really testing. So where we've come from and where we're going, we have worked to develop personalized risk stratification tools for the outcomes that are salient to our patients. I think we're really moving into this idea of deep phenotyping frailty, trying to stay away from the reductive, take advantage of all the data that we're getting, but figuring out how to leverage that and use that in practice to then define and develop and direct our prehab protocols. And then it's all about building these bridges between the diverse teams so that we leverage all the expertise in the room to mitigate these risks. So these are some of the amazing people I get to work with and who mentor me and are part of my bladder cancer team. And then I think a big part of it also is, the story of the really amazing team that we're building within urology oncology and trying to create opportunities to sort of expand space for all of us to have a chance to have our voices heard. And so with that, I'll say thank you, and I'd be happy to take any questions.
Three quick questions. One is the sarcopenia actually respond to exercise preventable as exercise? That's one. But I'm also curious if it tracks with the body type distribution. So this disorder